If I have a muscle injury, then most of the muscles on the side will kind of create that type of problem, where I'm tilted to the same side, but my chin's rotated down. So you kind of see that. So, but in general, you kind of see they're tight and everything, but kind of the way they're holding themselves tells you whether it's a sprain or a strain. And not that we don't care about strains, but if we think sprains in this area, then we're really worried about the spine. Try to put that up. I keep looking for the clicker that I have. The general palpation is we're just generally palpating their skin or elsewhere on their body for, kind of shock type of things. So for moisture, temperature. We're palpating their facet joints. So the facet joints is I'm coming straight down the middle. So I'm going to come straight down the middle here. Is that straight down the middle on each of the spinous processes. I'm then going to go on either side of the spinous process and look at the transverse processes. But remember, the transverse processes are almost nothing in these. So what we're really palpating is the facet joints. The facet joints out of place, which may be some of the pain he's having because the facet joints come out of place and it's pinching the nerve. I'm also going to palpate the occiput in here. And then kind of behind the ear, that is the mastoid process. Soft tissue palpation is I'm palpating the larynx, looking for crackling or anything. So up here it says, or on your sheet it says that I'm looking for fractures or contusions. But what you would actually feel, I can't help it, is you feel crackling. It isn't solid when you go to touch it. It just, okay, you get cracked, isn't it? We're palpating the trapezius muscles. And we're kind of palpating from where the trapezius attaches to the skull down to the spine of the scapula. So just the upper part of the trapezius that's doing this. So I'm just palpating that upper part of the trapezius, looking for strains. I'm palpating the paravertebral muscles on either side of the neck. I've got the left and right on either side of the spine, looking for pain or tenderness or knots or tears, whatever. The scalenary muscles and then the sternomastoid is the order I think you have it on there. But I do the sternomastoid first, and if you don't know where it's at, you have them do the old, can you kind of, make a face for me and pull your jaw down, and relax. So there's the sternomastoid. I know the trapezius is here. So the scaleni are kind of in that area between where your fingers sink in a little bit. And if I were to push a lot, then that kind of hurts because I'm pushing on the nerves. Then we don't have any stress tests per se. We have special tests. And the first special test is, yes, that was the one where I had to go her.
I thought that was the splint.
And then the spleni is that one in between where I was digging in. And then, so these are tests, the next 4 tests are all for a disc herniation or calcium filling up in the canals, which is that stenosis. Okay. So I'm trying to aggravate or relieve his symptoms of kind of the pain that's starting to shoot down into his arm. So the first is that cervical compression test where I'm compressing down on the spine and closing all those canals off a little bit, and that should exacerbate his problems. The opposite is the cervical distraction test. This one shows a person lying down, which is technically a much better position to do it in, and much more in control. But if I were doing it in this position, I'd be doing the same thing. I'm holding from the lying position is I'm supporting the jawline, hooking up behind the mastoid processes in the ears, and I'm attempting to distract and that only relieve some of the pressure. And then the next 2 were ones where we skipped that one, was the Valsalva maneuver. So we tell him to hold his breath and just bear down really hard, see if that creates any problems, which doesn't tend to do as much in the cervical spine as it does in the lumbar spine, so re-aggravate things there. We're going to find out he has a herniated disc there all of a sudden when we're checking this. So the other thing we do is swallowing, because that spine is right up against the esophagus. So we have you pretend that you're trying to swallow something that's really hard to swallow, and you're literally trying to, swallow that down. And a lot of times that exacerbates that. So then we took out the brachial plexus test, okay, because I did change the forms. So on the back side of your sheet, you have the 3 different thoracic outlet syndrome tests. And all 3 of these tests, I'm finding Dennis's pulse. I'm using that pulse. I'm trying to, see if as I do this, does the pulse weaken or disappear? There's what I'm doing to the victim, patient, and what I'm having them do. So this one, the position is, I'm just doing this, and you wouldn't have to explain in all this detail, but it would just be pulling the arm back like this. So I'm hyperextending it, okay, so if you see on there, I'm hyperextending it, the shoulder just abducted a little bit, elbows extended, thumbs up, I'm kind of externally rotating, okay, I've got his pulse there. At the same time, I'm going to have him extend his neck and turn to the same side. So when I go to pull your arm back, what I want you to do is look up as high as you can at the ceiling and rotate this way. Okay. So I'm ready. And turn. Strong pulse. Some other people we know or we lose the pulse every time. So that's the Addison's test. The military brace test is now I'm having the patient kind of retract, press their scapula, hyperextend their neck. So what I'm going to have you do when I'm ready to do is I kind of want you to pinch your shoulder blades together and look up at the ceiling as high as you can. And I get the pulse, and this one's much simpler for me. I just hyperextend his arm and kind of shoving forward on here. Okay, so if you can pinch your scapula together and pull your neck back. So I just do that in military brace position, so we'll strong pulse there. Have you had any problems with thoracic outlet before? And goes down to do that. Right. And then the last one's that Allen's or hyperabduction. And in this case, not quite like that picture shows if you have the slides. But on this one, all I'm going to ask you to do when I'm ready is just rotate your head to the other side. No hyperextension for the first time. And this one, the position would be a little better up here, but I've got an abducted 90-degree bend, and I'm just going to kind of force you into a little more horizontal abduction and kind of externally rotate at the same side. Find your pulse, there it is. Okay, and rotate to the other side. Can you feel that against my finger? I watch you turn to the other side. Notice how I'm losing it. That was so interesting. Okay. So anyway, so one of the 3. Okay. So that's the hyperabduction test. Okay. Then we start going through range of motion. In range of motion, we got flexion extension and flexion extension are both going to be the ones where I have this at the ear, so this is at the external meatus. Technically, this one, the stationary arm stays parallel to the floor, and then I'm either going to have you tuck your chin in as far as you can to your chest, so kind of whenever you're ready, and then I'm going to point that towards the bottom of the nose, and there's the angle of difference. Or I'm going to have you look up as high as you can towards the ceiling and keep that parallel to the floor and go to the bottom of the nose. That's the angle of difference. There's your flexion, extension using the nose. The lateral bending is now technically, this is going to be here at the top of the manubrium. The stationary arm is going to go straight down the sternum, and I'm going to have you trying to make sure you don't lift your shoulder at all, that you just bend to one side or the other. So if you just come to that way, okay, and maybe to the other one. But so what I'm doing here is, in this sense, we're all aligned here. Okay, can you bend to your left side, realign that with your nose? So there's my angle of difference, and we can do that to the other side. And then the rotation one was that kind of funky one. Oops, went a little too far. The rotation was that funky one where this is on the crown of the head. This is kind of with the two AC joints more that I want to, and I really should be higher than you because while I'm doing it, I want to make sure your AC joints stay lined up and you're not cheating by rotation by just pulling that shoulder forward. Okay, so I keep that aligned with the AC joints. Okay, bring that one up there, and then could you rotate to your right? I think was the one we practiced. Position there at your nose. So between there and there was our changing right. That was our rotation. And then we had all the different muscle strength tests. So we had flexion, and if we wanted to not move the patient all around and just do it from a sitting position, then the idea is if I can have you look at the roof, then I'm going to have you pull your chin down your chest. Okay, go. So I'm going to give resistance here, keep going. So there's flexion, so that would be both sternomastoids. I've got extension, not that way. So here I would have you start with your chin to your chest, stabilize here, hand on the back of the head. Okay, pull back, keep going until your eyes are looking up at the roof. Okay, so there's your extension. So that's going to be the paravertebral muscles, the trap, some things like that. Lateral bending is going to be the scaleni on that side. It would also be the trapezius, but I'm not letting him use his. So some people will say that, but I'm not actually letting him use his shoulder, so it doesn't become the trapezius. So it depends on how you want to do it. Let's say if we're doing it to his right side, is I would hold the shoulder down and start with your ear towards your left side here. I'm going to do the side bending. So we do the side bending, which is just bend straight to the side. And I give you resistance here. I want you to come towards this hand. Bend, 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 bend. Okay. And obviously I can do that on the other side. Okay. And then the rotation's going to be the sternomastoid on that side. So again, if I have rotation this way, so if I rotate you starting that way, is I don't want this shoulder to come forward, and I'm giving resistance here. A lot of people do it like this. I actually kind of like reaching across. I'm going to have you turn towards this shoulder that I'm touching here. Okay, you ready? Yeah, just rotate. Okay. Or I could have done it, if you want to start back over here, is I could have done it this way if you like. Either way, but I'm stabilizing the shoulder to give resistance to that rotation. So that's the sternomastoid. I think we crossed out the shoulder shrug. You can do it if you want. Motor function, I think we crossed off C5. Yeah, because we wanted to just be careful. So this is the idea. He's on the ground. He's injured. Everything's stabilized. I'm holding down your elbow and arm because I really don't want you to accidentally move that. And I'm just saying C6 is can you pull your hand back for me? Extend your wrist. C7 is wrist flexion and finger extension. C8 is finger flexion. And T1 is ab and abduction. So technically in motor I should give some resistance to these, right? So it should be extend your wrist. Flex your wrist, extend your fingers, grip my hand, flex your fingers, okay, spread your fingers apart, squeeze my fingers. So we're kind of walking right through those. And then the neurological was starting on the big thumb side. This is C5, thumb is C6, long finger is C7, pinky is C8. This side of the forearm is T1. Just making that our 5, 6, 7, 8, because there are 8 cervical ones. T1. Okay. And then the other thing is we're taking the pulse. We're kind of looking for quality of the pulse, what's the rate, the strength, the rhythm. And then the BP cuff. Get the BP cuff. And I think we demoed that last time with the heck. We're running out of time. But you don't really have to take it up and get all the numbers and do all the pumping and everything, but it's just more that, the idea that I'm putting the BP cuff on it's not covering that area, so that's kind of one point. So I think I was looking for 6 things. So that's one. The second is that the stethoscope goes in this area. The third, the third is in terms of pumping it up. I pump it up until I lose the pulse and take it another 20. I take it up and get another 20. And then I let it down slowly